Thank you, the chair, and good afternoon, everyone. I welcome you to the presentation entitled The Contribution of Muscle Tone, Upper Limb and Lower Limb Motor Function on Fall History in a Community Dwelling Individual with Stroke. As we know that stroke is the foremost cause of long-term disability. The factor related disability were motor impairment, somatosensory deficit, and higher brain dysfunction, with further leading to activity limitations such as poor postural control, poor balance, poor postural control and balance, poor ambulation and dependence in ADL. Among impairment after stroke, motor deficits were significant problem that includes poor movement control of upper limb and lower limb in one side and increasing of muscle tone or spasticity. Moreover, the prolonged reduced movement of extremity was the cause of muscle weakness in stroke patients. Disability following stroke lead to serious problems, and four are the most apparent complications after discharge from hospital. Both prospective and retrospective studies have report high fall rate in individuals with stroke, range from 23 to 70%, different from follow-up period, and with incident rate at 2.84. The high fall rate caused the concern of public health because of serious consequences at individual and societal level. For individual level, physical injuries are very reported, especially fracture and soft tissue injury. Fall also have negative impact on psychosocial function. The individual would change their behavior to prevent future fall, saying the concern for fracture or other physical injury. After fall, the individual will develop fear of falling, with further increased adverse effect on ADL. In addition, fall following first stroke were major reasons for receiving medical treatment, which caused economic issue and stress on caregiver. Many studies have shown that stroke patients in follow group had more poor balance control and gait problem. Than non-follow group. The measures commonly used were performance-based measurements such as time up and go test, gait speed, and work balance scale. Poor balance control was commonly reported among individuals with stroke with fall. Therefore, the motor impairment which influence to balance were interesting. The motor impairment which influence to balance including the control of body part of leg, arm, trunk, neck, or head, eye, and head. This part generates the appropriate movement to maintain body in the upright position during any posture or activity, focusing on the contribution of upper and lower extremity to balance and fall. The study reported that approximately 50% of individuals with stroke who had no fall recover balance by using arm movement, more often by holding something among them, and 56% using both arms, 44% using paralytic arm to keep from falling. In addition, there were findings that the individual demonstrated the decline in contribution of paralytic leg for standing balance. They also show increase of postural sway in AP and ML direction and asymmetrical weight bearing. The change indicates postural instability during stand. The impairment in lower extremity, including loss of selective muscle control, plantar flexor muscle weakness, or spasticity, took responsibility for instability during stand. Moreover, during external balance perturbation, when increasing amplitude and velocity of perturbation, compensatory step, individual with stroke will use compensatory step with non-paralytic leg be used to reposition base of support. The individual with stroke had tendency to increase movement time of the stepping reaction. The study revealed that impaired loading weight on the paralytic leg could delay the timing of compensatory step. Moreover, previous studies show that the impairment of upper limb and lower limb motor were considered have the effect on gait. The propulsive force during walking that come from plantar flexor muscle. They found that spasticity or plasticity could induce premature muscle activity, and more premature muscle activity resulted in difficulty in moving the stationary foot in the standard of gait cycle. Moreover, weakness of plantar flexor related to decreased walking speed. Okay, previous study have shown that impairment of upper limb and lower limb motor function were considered as risk factor of fall. However, the relationship about the muscle tone, lower limb control, and ankle plantar flexor strength were not reported. Therefore, the purpose of the study was to examine the relationship between motor function and fall in community-dwelling individuals with stroke. The measurement including modified Edwards scale of elbow flexor and plantar flexor, Fuchs-Meyer score of upper limb and lower limb, ankle plantar flexor strength, step test, Berg balance scale, and time up and go. The participant will be a stroke, first stroke from 6 months, age greater than 35 years, and have unilateral hemiplegia, living at home and able to walk independently at least 6 meters, having score of TMSE greater than 24 points. The exclusion criteria were if they are having other neurological there are serious conditions such as fracture or the unstable condition. After record a participant, the assessor will correct demographic data. The one assessor will using performance-based assessment, and the other will correct the fall history and circumstance of fall, which are due at the end of the assessment. Fall data include the number of fall at home in the previous 6 months, and a fall was defined as an event of unintentional coming to rest on the ground or lower surface that was not result from a dyspnea or other overwhelming external factor. The participants who suffered fall once and more were classified as follow group, while the participants with no fall were in the non-follow group. To examine the relationship, binary logistic regression was used to analyze the relationship between the factor with odds ratio at 95% confidence interval. 248 individuals with chronic stroke volunteered to participate in the study. For the group comparison, show that demographic data of both groups look very similar. The present study found significant difference of muscle tone of elbow among faller and non-faller, and also a muscle tone of plantar flexor of non-faller and faller. And another measure, including Fuchs-Meyer scale of upper limb, lower limb, total score, ankle plantar flexor strength, step test, and Berg balance score, time up and go, were different between follow group and non-follow group. From the comparative characteristic of motor performance, the results show that the participants with fall have worse performance than non-faller. The relationship between the measurement and fall we analyze using crude odds ratio at 95% confidence interval and use adjusted odds ratio were the right. The adjusted odds ratio were assessed for age, gender, BMI, time in stroke, a weakness size, representing of other conditions such as hypertension, diabetes mellitus. The study found the modified adverse scale of muscle tone of elbow flexor and plantar flexor were strongest risk factor of fall. The participant with a modified adverse scale of elbow flexor and plantar flexor greater than or equal to 1 had about 3 times of fall compared to those with MAS score less than 1. The result, The result of the present study agree with a previous report that found the association between a spasticity of lower extremity and fall. Moreover, the present found high relationship between spasticity of upper extremity, therefore indicate that increased muscle tone of upper limb and lower limb were associated with fall. The crude and excess odds ratio of Fuchs Mayer score of upper limb and lower limb portion and the flexor strength were statistically significant. The findings show that increase of 1 unit of limb, the rate of fall increased like upper limb. The rate of fall increased 0.98 times. A previous study found the higher score upper limb movement had tendency of repeat fall. Therefore, it indicates that poor performance of upper limb movement was related with fall in participants and maybe the risk factor of fall in the repeat group. For lower limb, for the lower limb movement, individuals with acute and subacute with lower limb function had fall about 2.2 times compared to those with good control of limb. However, our study had less performance of lower limb, and it suggests that the individual with less performance of limb fail easily. Plantar flexor muscle is essential for standing balance. Moreover, it requires for gait stability. The study found that odds ratio of ankle plantar flexor close to 1 point. Therefore, it was not. It may not the important risk factor. Usually, ankle plantar flexor muscle work together with dorsiflexor. The present study suggests to do further study about the relationship between ankle dorsiflexor. The ST is one important measure of paralytic rate ability to loading weight. The study found that high relationship between step test and agree with a previous study. Therefore, step test was the important measure of fall risk. Moreover, the study found the relationship between Berg balance scale and time up and go also. For the time up and go, in previous study, found the odd in a big number, like 7.84. However, it's different from our study. Time up and go is a small number. Therefore, when using time up and go for predict fall, we should consider about the time of correcting data. In the previous study, they correct data of fall like in prospective study in 12 calendar, in 12-month calendar. In the conclusion, the participants with fall present poor motor impairment than those with no fall. The study support the essential of motor control improvement in fall prevention program. Okay, thank you for participation and welcome for question and suggestion.
Okay, thank you, Dr. Kalaya ค่ะ and any questions from audience ค่ะอาจารย์เฟื่องฟ้าค่ะเชิญได้เลยค่ะ
Thank you for your presentation ค่ะอาจารย์กัลยา Could I ask about what is the clinical implication for your results that you will take the message to suggest the stroke patient in the community?
For the suggestion, I think we should concern about upper limb, lower limb movement, and also spasticity of upper limb and lower limb for predict or for evaluate who at risk of fall, because right now sometimes we will focus only on balance, but like the movement, the motor control usually have contribute to balance. Therefore, I send the message that should assess and should consider about the movement, motor control also.
Okay, but another question is, it's quite hard to teach the caregivers or the patient to learn about the exercise for all of those kind of your aspect. Could you reorder about which one could be first, or it depend on the impairments of the patient or something? Could you suggest about the influencing in your data, please?
Okay, the easy way if we would like to introduce a caregiver of our family or patient, the thing that it should maintain like flexibility of muscle, especially elbow flexor and plantar flexor, by doing like a prolonged stretching for reduce the effect of prolonged spasticity, because prolonged spasticity can make like limit ROM and muscle stiffness. Therefore, that is an easy way for caregiver to doing like stretching for us. That is the first. Another is to exercise for upper limb and lower limb, right? For upper limb, as we know that patient the follow group will like use less affected arm to protect them from fall. Therefore, we need to have like other device at home, such as parallel bar, or if they cannot install the bar, they make use like stable furniture such as carpet or pillow or the wall in house during the walk. It can prevent fall easily.
Okay, hi. Thank you so much.
Ajahn, we have another question from Professor.
Yes.
In the chat.
In this chat.
No one's of the slides you suggest sensory input may play a role along with the UL/LL. All right. Motor aspect. Could you possibly elaborate on the sensory deficits that may be affecting them, please?
As because of in this study, I focus on motor impairment, but in another study of mine, I found that the sensory deficit, the relationship between sensory deficits such as the impairment of touch and proprioceptive didn't have relationship with fall. The one thing that is maybe the patient who have the deficit of both motor and sensory deficit may have like more severity, and then they didn't walk a lot in their house. When they didn't walk a lot, the risk factor of fall will reduce, because fall used in stroke patients frequently occur during walking. Therefore, I didn't show the data about sensory deficits in this study.
Sorry, if I may quickly. The reason I was asking is that if you're seeing a change in the motor outcome and you're talking about the proprioceptive or the signal from the afferents, the muscle itself is going to change the sensory drive because it's a spastic muscle, right? So if you're increasing flexibility of the muscle, which you indicated, that would alter the sensory input. Do you think that would play an important role in helping improving function, or do you think the sensory is going to be independent of the motor improvements?
You mean if we improve improve spasticity, right?
Yes. So if you're able to reduce spasticity.
Yes. Several studies found that sometimes spasticity and motor. Some studies found not associated, but we found that spasticity, in previous study found that spasticity have effect on the level of function more than like only the movement of one joint. In some study found when a patient who have more spasticity will have like take time in time up and go, and have a high balance, have poor balance score. Therefore, I think the spasticity may not like the effect only the movement of single joint, but it will be affect at the level of function, as we found in the previous study.
Okay, thanks. Yep. Makes sense.
If there anyone have any questions more, so you can leave the questions in the chat room. So please, the presenters, please answer them in the chat room, please. And so I think it is time to go on to another sessions for the biomedical engineering area. So thank you for every presenters and chairman and every honored guests and participants from the physical therapy. But anyway, if you are interested in our areas for biomedical engineering, maybe to connect our research together, and you want to listen to the talk, because we're gonna have 3 special talk in these sessions. And so I think we're gonna continue, and you can stay here. Okay, you can still stay here to listen them